Ladies and gentlemen, Mr. Chairman, it's a great honor and pleasure for me to present a quite new chapter in the STEMI guidelines. It's small, short, but new. So, in patients with STEMI, we recommend PCI as the primary treatment, but sometimes we end up standing like this, we find no stenosis. Quite recently, an ESC working group position paper on MINOCA was published dealing with this condition. And what is MINOCA? The diagnostic criteria for MINOCA is the following, and the diagnosis is actually made in the cath lab. We have a patient with suspected STEMI, but we find no stenosis. So the patients fulfill the universal MI criteria, but we find no significant stenosis in any potential infarct-related artery, and there is no clinical overt specific cause for the acute presentation. In that position paper, the following flow chart was presented, and if we have a MINOCA patient, we have to think a step further. What is the underlying cause of this condition? And sometimes we can find it out, I will come back to that, but sometimes we cannot, and then the position paper authors recommended to do an MR, cardiac MR. This is data from a large meta-analysis looking at the cardiac MR imaging results when the examination was done within 6 weeks after the MINOCA event. And as you can see here, 33% of the patients had a myocarditis, and 24% had a real acute myocardial infarction observed on the MR examination, 18% had a Takotsubo, and in 26% of the patients, no definitive diagnosis could be determined. So myocarditis is different to have in your backhead when you deal with MINOCA patients, because it might have a similar pain history as a patient with acute myocardial infarction, and troponin might be released, and where patients may have ECG changes, and we have no specific biochemistry markers, and biopsy is risky sometimes, so MR might be a new gold standard here. So if we look at different studies on MINOCA populations, the prevalence seems to vary between 1% and up to 13%. The population is heterogeneous with several potential etiologic diagnoses, and it's a working diagnosis. If we have a patient with heart failure, it's the same situation. We have to think a step further and consider why has this patient heart failure? Is it a dilated cardiomyopathy, or is it coronary artery disease? And the same is true for the MINOCA population. So a routine examination with CMR imaging may be recommended. And failure to do so may result in the patients do not get an adequate therapy, or, which might be even worse, inappropriate therapy. So what conditions are we talking about? It might be secondary to epicardial coronary artery disorders, thus plaque rupture, ulceration, fissuring, erosion, dissection, or an imbalance between oxygen supply and demand, thus a type 2 myocardial infarction. Other possible reasons are coronary endothelial dysfunction, microvascular spasm, or secondary to myocardial disorders without obvious involvement of the coronary arteries. That's mostly likely myocarditis or Takotsubo. So coming back to this large meta-analysis, this table figure shows the prevalence of MINOCA in different myocardial infarction population, and here the result was 6% of a myocardial infarction population. And one might believe that this is only end-STEMI patients, but that is not the case. According to this meta-analysis, 1/3 of the MINOCA population consists of STEMI patients. What about prognosis? According to this study, on the left side, comparative studies, the 1-year mortality in patients with MI and coronary artery disease was 6.7%, but in the MINOCA population it was 3.5%. And if including all MINOCA studies, the 1-year mortality rate was 4.7%. Thus the condition is, it's a serious condition, so we have to handle it. So this is the diagnostic test flow chart presented in the present guideline. So we have a patient with a suspected STEMI and bring the patients to the cath lab, but we find no stenosis. And then we have the MINOCA in our minds. And then we have to consider further examinations to find out the underlying cause. And as said, there are several possible underlying causes, and myocarditis is one which is quite common, and where MR might be the most reasonable way of finding out. This is a non-invasive and quite good examination to perform as fast as possible. It's also possible to do an invasive approach and perform a biopsy. We might look for coronary reasons, and of course we do echo in all patients with myocardial infarction. MR might also help to identify small infarctions. Transesophageal echo is another possibility. And there are invasive examinations which maybe should not be used as a standard examination, but might be considered in special cases, and that is IVUS or OCT to look for plaque disruption or dissection, spasm tests, or looking for microvascular dysfunction. Myocardial disease, another possibility, and again Takotsubo, which we often find on standard echo, but sometimes we may have use for an MR as well. Pulmonary embolism should we have in our backhead, and as said, type 2 myocardial infarction is also a possibility. So coming to the conclusion about this small chapter is that MINOCA fulfills the acute myocardial infarction criteria. It's a quite common condition, 6% of all patients with MR, and it's not only end-STEMI patients. And the MINOCA syndrome is heterogeneous, and as such, there is no common pathophysiological mechanism. And it's a working diagnosis, so we can't stop there. We have to think about the next step to identify the underlying cause of the MINOCA. And as I said, failure to do so may cause that the patient do not get the appropriate treatment or maybe treated with pharmacological drugs. And MR might be considered as a standard examination when the underlying cause is not identified. Thank you.